Buenos dias, good morning. First, we'd like to acknowledge the traditional custodians of the land in which we meet today and pay respect to the Burungrong, Bunwurrung, and Wurundjeri Woiwurrung people of the Eastern Kulin Nation. We pay respects to the elders of the community and extend our recognition to their descendants. We know that sovereignty has never been ceded. This has and always will be Aboriginal land. This makes a dispossession and theft of the land of what is now so-called Australia from Aboriginal people, an act of extreme cultural and colonial violence. Buenos dias, I'm really excited to be here today. My name is Rafi Torruella from Intercambios, Puerto Rico. It's a privilege, especially with this amazing panel that we have today. Today, we're talking about collective liberation. That's not a small feat for today. So, radical approaches to health. And today, I have an amazing panel of 4 individuals: Professional James Ward, Dr. Seree Nonthasoot, Phelister Abdalla, and Yevgeniya Kuvshynova. I will present first Professor James Ward, which is our first speaker. Professor James Ward is a Pinjara and Nukunu man and an infectious disease epidemiologist and a national leader in Aboriginal and Torres Strait Islander research. He is currently the director of the Poche Center for Indigenous Health at the University of Queensland. Holding various roles over the last 25 years in Aboriginal public health policy for both government and non-governmental organizations in urban, regional, and remote communities, he has built a national program of research in the epidemiology and prevention of infectious diseases, with a particular focus on STI, HIV, and viral hepatitis in Aboriginal and Torres Strait Islander communities. Without further ado, Professor James Ward.
Thank you very much. Good morning, and thank you to Harm Reduction International for the invitation to speak here today. May I begin by acknowledging the traditional owners of this country, the Bunurong, Boonwurrung, Wurundjeri and the Woiwurrung peoples of the Eastern Kulin Nation. Thank you for your generous welcome to all of us here on your country and for the duration of this conference. I want to acknowledge your ancestors, many thousands of years of custodianship, care and protection of these lands, and acknowledge that these lands were always places of scholarship and learning. May I also acknowledge Aboriginal and Torres Strait Islander people here today, as well as other First Nations and Indigenous peoples who have travelled here to Melbourne. The topic of my talk today is decolonising harm reduction. What is it and how do we achieve it? But first, and as is with traditions, I want to position myself. Wanyuntulpaya Purula James Nulo Ananu Nukunu. I want to acknowledge my own ancestors who always held and included our people in the circle, who always maintained country and have guided me and held in balance through culture, custom, dance, song and stories, 4 critical paradigms to our peoples. First, the Jukuba, which can be best described as the profound bonding of our people to each other, to the country they belong to, the species of animals and plants on their country. Secondly, Janura, the philosophy of caring for country that we belong to, and that is subject to obligations of looking after it and caring for it. Third, Walcha, the system of extended kinship and the organisational scaffolding of our societies, formed intricately for social roles, relations, authority, as well as the pathways for communication and distribution of resources. And finally, Kanyeni, the concept of having, to hold, to care. It's a commitment, a full engagement, vitalising again and again all that went before and all that will go after. It's these 4 paradigms, their balance, their relationality to each other, that have been used to guide survivorship of my peoples that have lived on this land for at least 60,000 years. In also positioning myself, I want to perhaps state the obvious, that drug use is not new, it's not inhumane. I recognise human beings have used psychoactive substances for millennia, for ceremony, for rituals, for pain, for culture and for trade. Here in Australia, among my own peoples in Central Australia, who are known as the longest surviving peoples with continuous culture on the face of this planet, the use of psychotropic flora have played an important function in our survival and cohesiveness of communities since the beginnings of human history. One such example is the plant Euboisia, or commonly known as pitchery. It has been used to create states of consciousness, particularly hypersuggestible ones, to enculturate adolescents that subsequently contributes to the survival, cohesion and success of our community clans and groups. Pitchery has also been used for extreme pain relief, for long walks, for ordeals. Pitchery is accepted as of sacred origin and is treated with awe and reverence. These plants are in limited supply and were protected insofar as they remained under elders' control and administration. This, in essence, means that Aboriginal peoples were some of the earliest adopters of harm reduction. Beyond Australia, contemporary substance use among Indigenous peoples today is inextricably linked to colonisation, both in the ways land was acquired and in relation to the disruption and trauma for our Indigenous peoples globally that came with it. It is apt at this conference and on point with this talk to point out that psychoactive substances such as opium, tobacco, alcohol and cocaine were used by the colonial powers to achieve their goals of dispossession of lands and peoples. These same commodities ensured the colonial experiment could expand to more lands and to continue to ignore, displace, disrupt and massacre Indigenous peoples. At the same time, the introduction of drugs and substances to Indigenous peoples has had devastating impacts on our peoples globally. The result? Indigenous, black and brown peoples who use drugs are over-policed, have higher rates of arrest, fatal overdoses, prosecution and incarceration for drug use than any other identifiable population. And at the same time, they lay bare their bodies to the triple whammy of discrimination, racism and stigma. This has resulted in higher rates of HIV and hepatitis attributable to drug use amongst our peoples. So it begs the question, what is it about current harm reduction policies that is not working for Indigenous peoples? A key principle of harm reduction in drug policy is to move away from the abstinence-based program model to one of minimising harms for people who use substances. Harm reduction has been in operation as a policy now for around 40 years, and I'm sure most of you in this room applaud harm reduction as a strategy, as I do. It has no doubt worked in saving many millions of lives globally with interventions such as needle syringe programs, opioid replacement programs and supervised injecting facilities. So, to decolonising harm reduction, what is it and how do we achieve it? Decolonising harm reduction, broadly as a concept, means deconstructing colonial ideologies of superiority and privilege of Western thought and approaches to disrupt the colonial experiment and its intent. It means moulding harm reduction to the cultural values, paradigms and meanings that Indigenous peoples holds. Decolonising as a concept may seem radical to some, but I sincerely believe it is also ethically and morally the right thing to do. Firstly, I want to say that decolonising harm reduction is everybody's business. Decolonising harm reduction as everybody's business means us self-reflecting and taking action to dismantle systems and structures that perpetuate the status quo, the unbalanced power dynamics in our society. A first step in decolonising harm reduction is to recognise that we're all living on lands that have been surrendered, that have never been ceded, and for the great part have never been recognised by the colonisers. If you take a moment to ask yourself a question, where were your great-great-great or great-great grandmothers or grandfathers born, then on whose land, territory or treaty were they born on? Confronting as it is, in some ways most of us have a family history of colonisation, and surprisingly most of us don't know it or recognise that. This means that our ancestors were complicit in the concept of colonising lands. They were either active in the takeover and exploitation and disruption of Indigenous ways of knowing and doing, or they were silent bystanders. They were citizens in a time where eugenics and white supremacy were actively pursued as legitimate paradigms, and when conquest and rendering others as inferior was normal. Like it or not, colonisation and its ongoing legacy is a major contributor to the overrepresentation of Indigenous peoples globally in all the state-enforced negative aspects of drug use. We are all innocent inheritors and custodians of that history. It's not your fault, but it is, I think, important for you to learn this history and acknowledge the privilege that has come with that, and then decolonise the way you do your business. All of us need to pick up this damage, come together and collectively clean it up. Decolonising harm reduction also means celebrating and understanding who we are and connecting with the unique knowledges that we all bring to the table. Harm reduction in Indigenous communities is about local governance and empowering communities to determine appropriate harm reduction strategies. Giving Indigenous populations a voice is decolonising practice. For those of you who are visiting Australia, later this year we'll hold a referendum to enshrine an Indigenous voice to Parliament. This technically will mean Australians vote to change the founding constitution, and if successful, policy making will be amplified with the voices of Indigenous peoples who bring to the table context, expertise and lived experiences. When we give voice to people, we can then begin to solve the challenges we're currently facing in the harm reduction space. A voice is a mechanism for us to be seen by governments and corporations, and for us to see ourselves as an integral part of the responses that involve our own peoples. Decolonised harm reduction also means recognising context. It has to honour our history, our identity, our culture, our politics, and the impact these collectively have on us today. Simple recognition, either with a welcome or acknowledgement of First Nations lands, culture and leadership every time we gather in groups, is not enough, but it is a critical starting point. Having an understanding of the social structures in our communities, the non-hierarchical structures, the concept of storing, of time, of place, of synchronicity, of balance, of relationality, is much more good decolonising practice. It is about giving over the power and empowering our own peoples to make decisions regarding drug use, drug control, drug treatment and drug enforcement. Rekindling the ways in which we considered drug use prior to colonisation is decolonising practice. That is, thinking about drug use for cultural rituals, for ceremony, and a roundabout way as a public health issue, even before public health was termed a discipline. This recognises that our people have always cared for our peoples. They always had our people in the circle. They always operated with principles of inclusivity, reciprocity, and fulfilling obligations to our clans and kin. Decolonised harm reduction is also about embracing the concept that health and well-being is about relationality, and that health and well-being is not only about the absence of disease, but about the physical, the spiritual, and the connection to land and kin. But most importantly, it's about all of those being in balance and in sync. Decolonising practice also means looking within the structures and systems we operate within, such as government health departments, for example, who predominantly work in hierarchical and clinical-led models of programming and resourcing. Addressing and acting on racism is decolonising practice, especially in the healthcare system. Too often, our peoples face racism when they attend healthcare, and too often it ends up in death. Over and over, many coronial inquiries in this country have pointed to racism as an underlying cause of death for Indigenous peoples in the healthcare system, either by being refused care, inadequately cared for or treated, or just simply turned away. Decolonising in this context means all of us unpacking the biases, the structures, the systems that operationalise racism in our own practice and organisations. Decentralising resource allocation and programs is decolonising practice by allowing sovereignty of communities to develop locally led solutions. Fundamental to all of this is an appropriate level of funding commensurate with need. Without this, it undermines the ability to make tangible and lasting improvements in Indigenous health. Finally, decolonising harm reduction recognises that not one size fits all. Decolonised harm reduction has to be more about the right strategy, at the right potency, with the right population, at the right point in time, and for the right length of time, if we're going to disrupt the status quo. And most importantly, that strategy has to be developed and led by us. Before closing, it would be remiss of me not to state that, over and all above harm reduction, what we collectively need to disrupt is the criminalisation of drug use and its ongoing impact, particularly for Indigenous, Black and Brown peoples. The war on drugs has never been a war on the root causes of drug use. It has always been a war on the people using drugs through increased policing, prosecution and incarceration. Until it is a war on the conditions which create the issue, it will continue to be a facade of action for political gain at the cost of people who need health interventions, not criminalisation. This war on drugs agenda continues the legacy of colonial powers and colonisation's intent, where criminalising and stigmatising drugs and making their use seem deviant has served to demonise, dehumanise and marginalise the communities who use them. This strategy has been employed the world over to harm and repress ethnic minority groups, political dissidents, the poor and the dispossessed. It is the polar opposite of decolonising harm reduction. So in closing, if each and every one of us move toward decolonising harm reduction practice, we can then allow our spirits to connect, and this will enable our people to heal people. To do this will mean we have to dismantle systems, our thinking, our privileges, our policies, and most importantly, connect, engage, and be with Indigenous peoples. As a sovereign person of this nation who is in his sixth decade in this life as an epidemiologist, as a professor in Indigenous health, I can say this: the Western society approach to harm reduction has failed to alleviate effectively enough, nor quickly enough, the disease, death and suffering among my people and many other Indigenous populations globally. Enough is enough. Decolonise, decolonise and decolonise harm reduction. Thank you.
Thank you, Professor Ward. Our next speaker is Dr. Seree Nonthasoot. He is a member of the UN Committee on Economic and Social and Cultural Rights. On October 2022, he initiated the development of a new general comment on the impacts of drug policies on economic, social, and cultural rights, and has been appointed by the CESCR as a lead rapporteur. Based in Bangkok, Thailand, he serves as a Senior Executive Vice President of the Institute for Research and Development for Public Enterprises. He is an expert in human rights, international law, corporate governance, and public and private partnerships. From 2013 to 2018, Dr. Nonthasoot has served as the representative of Thailand to the ASEAN Intergovernmental Commission on Human Rights, during which he initiated programmatic works on business and human rights, rights of persons with disabilities in ASEAN, and access to justice. With you, Dr. Seree Nonthasoot.
Good morning. I would like to start by paying respect to the Boon Wurrung and Wurrung-Jeri Woi Wurrung peoples of the Kulin Nation. I would also like to thank Harm Reduction International for the invitation to address the plenary today, which is a very engaging Tuesday for me. The theme of strength in solidarity could not have been more opportune. Many global challenges, including the one that unites us today, have been made worse and more complicated by the COVID-19 pandemic. I intend to use my time with you today to outline salient opportunities, 3 of them, for our mutual focus, activism, and advocacy. Unfortunately, ChatGPT cannot help write the personal message I'm about to deliver, so Naomi would excuse my absence from a few sessions from my personal reflection. My first point of our opportunity is that this is the human rights moment. This year marks the 75th anniversary of the Universal Declaration of Human Rights. The UN High Commissioner for Human Rights has initiated a whole of UN agenda to celebrate the occasion through a number of activities with a view to promoting universality and indivisibility, looking to the future, and bolstering the human rights ecosystem. In order to mainstream harm reduction internationally and vis-à-vis the UN system, we need to align our movement with the language they use and the agenda they set. Let me bring to your attention a point on language. While we have been advocating for the right to health of people who use drugs, we must be aware that the concept of health as part of an adequate standard of living has been there from the very beginning. That is the year 1948, when the UDHR was adopted. Article 25 of the UDHR states that everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care and necessary social services, and the rights to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond his control. Note medical care and sickness. In 1966, world leaders agreed to render more binding the commitment of the UDHR. Not only did they create two legally binding covenants, one on civil and political rights and the other on economic, social, and cultural rights, they further enhanced the notion of living standard, according to the International Covenant on Economic, Social, and Cultural Rights, which became effective in 1976, when there were 35 ratifications. The right to health is put beyond a basic standard of living. Article 12 of the International Covenant espouses this succinct provision. The states, parties to the present covenant, recognize the right of everyone to enjoyment of the highest attainable standard of physical and mental health. This is why I have always taken the view that the concept of human rights, especially the right to highest standard of health of people who use drugs, predates the first drug convention adopted in 1961. However, it comes as a surprise and dismay that as a result of the regime established by the drug conventions, we have been living with a paradox of logics. If you overconsume sugar and develop type 2 diabetes, in many countries around the world, you are entitled to get proper treatment. If you smoke and develop lung diseases, you can also get medical care. But if you use drugs like cannabis, which gram for gram may have less health impact than tobacco, you can be put in jail. And if it's opioids like heroin, you can get a mandatory death sentence instead of healthcare in case of overdose. This illogical equation has put human lives at risk globally for more than 60 years. States must be reminded that they are duty-bound to provide treatment and care for people who use drugs and abolish policy programs that reinforce stigma on them. This is a matter of responsibility and not charity or choice. For me, I'm doing my part with the Committee on Economic, Social, and Cultural Rights to develop a general comment on the impact of drug policies on these rights. I'll expound on the process in another session, but here I would like to highlight that my initiative on the general comment comes at a confluence of positive developments on the human rights of people who use drugs, and I'm proud to have contributed to this stream of positive currents. My main objective is to mainstream systematically the concerns for people who use drugs, and the general comment will be a key tool. Also equally important is the approach of the committee itself. At the committee in Geneva, we invariably ask state parties if they have deployed the maximum of their available resources to progressively realize economic, social, and cultural rights. We need to nudge the committee to inquire further. Why? Many state parties commit their resources disproportionately to punitive drug regime that in many cases deprive the lives of the very people we are created to protect and nurture, when those resources can be used much more humanely and creatively for their economic, social, and cultural development. Perhaps the most fundamental shift that we need is the integration of human rights principles by the people who administer the punitive regime themselves. And here we also see initial positive sign of reception. Increasingly, the Commission on Narcotic Drugs, the UNODC, and national agencies on illicit drugs and drug controls are making references to human rights treaties and principles. Obviously, we need to expedite this integration but we cannot do so through alienation and isolation. We must continue to engage. And thanks to the initiative of the OSCHR on the 75th anniversary of the UDHR and the mandate of the Human Rights Council for a report on impact of drug policies due to be considered at the midterm review next year, we can anticipate and advocate for further progress. My second main point of opportunity pertains to human development. Punitive drug policies and measures not only contravene human rights principles, but are a regression to the global agenda on sustainable development. My experience at home led me to have an interest in the drug issues. Thailand has one of the highest ratios of people in jail in the world. While the number of those in detention facilities has decreased as a result of COVID-19 conditional release, the number remains among global top tier. More than 80% of those in jail in Thailand, amounting to more than 200,000, are there because of petty drug offenses, mainly related to methamphetamine. Once in and out of jail, their criminal records are an indelible stamp of deprivation of jobs, food, shelter, and meaningful life. To me, this is a waste of human development opportunities. To make the matter worse, once deprived of opportunities, repetition of crimes is often their unchosen life choice, and they are for the most part trapped in perpetual cycle of crimes and stigmas. Imagine the progress that we could achieve if the drug regime is changed. Human capacity and contribution to global sustainability will be enhanced. From SDG 1 to 17, from now until 2030, the decade of action will be meaningless if it does not address this huge herd of elephants roaming the globe. I would also like to point to opportunity beyond the current SDGs. We need to ensure that the next global agenda currently under discussion has direct reference to drug policies. In disability rights movement, people with disabilities adopt a motto, "Nothing about us without us." Here too, people who use drugs and those who care for their livelihood must assert their relevance in global goals on sustainability, because the world is also about them and their future. My last point is reform models. We must not underestimate the effect of state silos. Units or agencies that are created to monitor drug policies tend to perpetuate the regime. Of course, model laws and regulations that are discussed here are ideal. There are excellent reports published by the Global Commission on Drug Policy, and there are models implemented in various countries, including those from Australia. Also ideal is the reform of the 3 drug conventions. While these are on our agenda, we must also seize the lower hanging fruits. There are a mixture of policy and practical measures around the world that show promise, even without legislative change, including establishment of interministerial or interagency coordination, diversion from criminal justice system, inclusion of methadone or naloxone as part of universal or basic health care, and distribution of needles and syringes that are based on sound harm reduction concept. And we must not undervalue them. When working on stateless people, I recall the campaign for states to adopt diversion measures that will not put them in detention as a result of their immigration status. Such diversion is also called for in the case of children in conflict with the law. They are diverted from the criminal justice system. It has also become successful in a number of jurisdictions. Perhaps these small but not insignificant steps can be similarly advocated for people who use drugs. I hope my presentation gives you some food for thought and call for further joint action. Thank you for your attention, and I cannot say enough how I look forward to working with you. In solidarity, we thrive. Thank you and have a great day.
Thank you, Dr. Nonthasoot. Our next speaker is Phelister Abdalla. She is a national coordinator of Kenya's Sex Workers Alliance. She is a co-founder of African Sex Workers Alliance and one of the pioneers of the sex worker movement in Africa. Phelister is on the front line of creating awareness and advocating for the rights of sex workers at national, regional, and global levels, including lobbying and advocacy for policy reform and leading in decriminalization of sex work in Kenya. She is known for addressing critical issues such as stigma and discrimination, violence faced by sex workers, empowerment of the community of sex workers, and inclusion of the sex workers agenda across Kenya and Africa. Phelister also serves on numerous committees and other boards representing sex workers and key populations in Kenya, Africa, and globally. With you, Phelister Abdalla.
Good morning, everyone. So today I want to take this opportunity and I would like to talk about collective liberation, radical approaches to the health. And I think one of the things that has really come out to us as a community before I start my presentation, it is a fact that all the time we go to conferences, all the time we occupy the spaces, all the time we work with partners, it is always about numbers, syringes, condoms. And there is nothing about me being a human being. It's high time. It's high time we start humanizing, putting a human face into the programming that we want to do with the community's members. Before I am a sex worker, before I am a mother, I am a human being. So try to humanize the programming so that things can move smoothly for all of us. A collective liberation and radical approaches to health can work together to promote one's equitable and just healthcare systems. For example, a community-based healthcare approach that involves community members in decision-making and care delivery helps to address power imbalances in healthcare and promote collective liberation. Similarly, health justice approach that seeks to address system issues of oppression can help promote collective liberation by creating a more just, equitable society for people. This means meaningful engagement for communities at all stages, from the designing, decision-making, implementation, and community-led experts. One of the things that people have never come to realize is that we are never peer educators. We are not just people on the ground to come collect data for you so that you can have that number. No, we are the people that you are coming to work with. We are experts because we are the people on the ground. And we bring that lived reality that nobody has, and we are the only people who are living that life. I want to give an example of community-led healthcare setups in Kenya. I want to give an example of Bar Hostess Empowerment and Community Program, which is a sex work-led organization that has been surviving for more than 20 years, and it's running community-led facilities, clinics in different towns in the city that are managed, run by the sex workers, which are actually giving quality data. Why? Because it is the community itself that is taking a lead. It is the community itself that is making the decision. And it is the community itself that is offering services to their fellow community members. I'm also taking this opportunity to appreciate the fact that we also have male sex workers, hoimers, us as sex workers, people using drugs and transgenders, decided to do a collective application to the Global Fund together. Why? Because of the issues that we are facing. And we decided to run one facility that was going to serve us, all of us as a community. And it is one of the best facilities, best practices that is doing the best work that is being done by the community members. One of the things I always say, the sex workers do it better and the communities do it best. Collective liberation, radical approaches to health are interconnected in that they both challenge traditional power, structural, and seek to address the root causes of social inequalities and contribute to poor health outcomes. Just like I've said it, we always do it better as the community. Some examples of radical approaches to health includes community-based healthcare, which involves working closely with community members to identify their health needs, developed tailored interventions. We've had partners who have come on the ground. They've come with brilliant ideas. We look at them, we admire them, and they come and they appreciate our lived life realities as the people on the ground, and they say, we would like to do a research. Our work, we will bring this expertise, but this is the expertise we also expect to come from the community. And those are the conversations we need to have so that we can be able to make a change into this world. Health justice, which recognizes that health is a human right and seeks to address the root cause of the health disparities, such as criminalization, accessibility, availability, and environmental declaration. So considering diverse, communities' health needs range from time and areas of operation. Intersectional approaches, which recognize that people experience health disparities differently based on their intersection, social identities and experiences to oppression, and seek to address this intersection in healthcare. Sometimes I sit like this and I am looking at some of my colleagues. So I want to give an example and say, I am a mother of 3. I've given birth to 3 children. But in my house, I live with 8 kids. Why? Because some of my community members were murdered and their children, I could not stand them going to the children's home. And one of my friends is an active injecting drug user who has decided to live into the streets because she does not want her children to see her. And those children deserved to have a home. My children asked me, do you love us all the same? And I say, no, I don't love all of you the same, but I have genuine love for each and every one of you. Intersectionality, it's about us partnering and working with each other as communities in a setup that it's not equal, but it is diverse. It is a space where I appreciate somebody else is different from me, but the challenges that we are facing are the same. How are we uniting the powers to make sure that we are making the difference? Today, I do not only want to talk about the key population. I also want to talk about the women who are coming from the rural areas, and nobody is speaking on their behalf. I also want to talk about the migrants, women and men who have migrated into our countries, and they have occupied our space. Who is able to give them that voice and making sure that they can be able to access the services equally the same as us? And this is where intersectionality approaches are actually working well, because when we talk about women, I do not want to know whether you migrated from another country or not. I do not want to know whether you are a transgender or not. All that matters, it is the fact that you belong to my community, and the service that I get, it is the same service that you're also supposed to get. Defining collective liberation, removing barriers to healthcare access for criminalized communities such as people who use and inject drugs, sex workers, LGBTQ individuals, and trans communities, adding the migrants. And indigenous women in most of our countries are actually criminalized. Today in Kenya or in most of the Eastern African countries, actually our countries are passing laws on getting rid of the LGBTIQ communities. And it is very interesting when you hear the conversations that our countries are having in the parliament. I want to tell you that the economy of my country has really grown to an extent. It is a few people who can be able to afford the 3 meals a day. So very few people, I think very, very few. But today, instead of the leaders looking at how we are going to make sure that the people grow along with the community or along with the people that they have been voted to serve, they are actually discussing a community that is in need. They are discussing about getting rid of innocent people, people who have made personal decisions of being who they are, what they want to do, and where they want to be. This has really affected not only the community, but programming on the ground. It means facilities have been shut down. Some community members are actually not accessing services today simply because our government is looking at passing laws that is oppressing community members. It means people have run away from the places they have always called home, and they have become strangers in places where they do not know where they belong. We have worked so hard to get where we are today. We have worked so hard to see community members like me standing here speaking about rights, inequalities, intersectionality, for people to take us back and say, my home is no longer my home. Today, where am I running with 8 children if today they say we do not want to see Phelister in this area? And that has been our lives, moving right in all the time. Let's talk about the legal barriers. Let's talk about decriminalization. I think it is time to put investment also in structural intervention. We understand our health is very important, but as you've seen, one attack can make that 10 years program go down in 1 hour. So when we are actually pushing for programming, let's not forget about the structural intervention. Let's not forget about the decriminalization of the criminalized population that today we want to talk about here and say we want them to receive the best services that they are supposed to get. Challenging power dynamics in healthcare, such as those between donors, doctors and patients, and working towards more collaborative patient-centered care. Have key populations as community health volunteers. Somebody told me that it is only in Africa where we have community health volunteers, and maybe in other regions we do not have them. So where I come from, we as communities, we are always used as community volunteers to make sure that we reach our other population. But this needs to be really integrated. Let people feel motivated, appreciated, and be seen like as if they can be able to lead, even if it is a program, especially when it comes to the implementers. Volunteers, workers at public integrated health centers to ensure community benefit from comprehensive care treatment, including eliminating mother-to-child transmission. I am a mother living with HIV. The first time I found out I was HIV positive, I was actually pregnant with my firstborn, and I had gone to a public facility. And I did not know about a mother needs to be tested for HIV before you start receiving all those services. So the nurse came back and she was like, oh, we tested you for HIV and your results are not good. And I was a first-time mother. And I was like, okay. And she said, oh, you are HIV positive, but there's PMTCT. That time we were talking about PMTCT those days. It is about how a service has been delivered. A lot has been done by the community. We have changed the narrative. We have changed the way the healthcare providers are approaching the issues today through the sensitizations that we have done as community members by telling the people how we want to be treated, how we can work together, and how this journey belongs to each and every one of us. It's not about me as Phelister, who am a woman living with HIV, who am a mother. This journey is about all of us. And it is about me making you understand, but you also being willing to understand and walk the journey along with me. Addressing systemic issues that contribute to poor health outcomes, such as gender income inequality and environment degradation. Prioritizing prevention and holistic approaches to health rather than solely focusing on treating illness and diseases. Employ KPs as prevention champions. This word of volunteering, it has been too much. Let the community now enjoy the salaries. As we have said, the economy has grown. Can the community grow along with it? Overall liberation, health involves recognizing the social and political factors, influence health, and working towards a more just, equitable healthcare system. What collective liberation means, how it has been achieved, and in history, why it is relevant. The sex workers-led groups, PWADs, transgenders, and the LGBTQ rights movement, which has involved people from different sexual orientation and gender identities working together to challenge the discrimination and achieve greater acceptance and equality. So through sensitization, as I've said, through the healthcare providers, and I think Kenya is one of those countries that we have the Key Population Consortium, where we have brought in all the key population to sit down, brainstorm together, do advocacy together, and we've made a lot of changes together. The feminist movement, which has involved people of all genders coming together to challenge patriarchy and achieve a greater gender equity. Members, today I want to confirm that as the sex workers movement in Kenya, we are the members of Femnet, which is a regional network of women. I want to recognize the fact that as sex workers, we are working with women and feminist movement. Not all of them, but the global network has come up to to make partners, women, feminist movement who are called SWIFA today, to show us who are the people supporting our agenda, even if we cannot be able to occupy the room, but we have feminist leaders, women leaders who can be able to run with our agenda into spaces where we cannot be able to occupy. And today I would like to appreciate the women's and the feminist movement for the great work that they've done along with us. Collective liberation is relevant to health because social inequalities and system oppressions can have significant impact on people's health outcomes. For example, people from criminalized communities may have less access to health care services that negatively affect their health by working towards collective liberation. My time is running out. I'm going to pass through my presentation quickly. By taking a radical approach to health, it is possible to create more equitable and just healthcare system that prioritizes the health needs of individuals and communities. This can help to reduce health disparities, promote health equity, and ultimately improve overall health outcomes for everyone. Protecting key population in turn protects the whole society. By you protecting us as key population, it means you are actually protecting the whole and entire society. It seeks to engage and empower communities in the process of addressing health issues rather than relying on solely medical professionals to provide peer-to-peer learning through engaging peer educators. And now on my last slide, collective liberation involves recognizing that liberation is one group of people interconnected with the liberation of all people, while radical approaches to health involve rethinking healthcare delivery for moving away from solely biomedical model and to address social and political determinants of health. Invests in directly funding to key population-led organizations. We do a lot of work on the ground. We have structures. There was a time you kept on telling us, build your capacities. Funders kept on reminding us that now we have the capacities, we have the system. Come in, let's talk about partnership. It's very important. This can involve educating oneself and other about the impact of social inequalities on health, advocating for policy change that address systematic issues of oppression and supporting community-led efforts. To address healthcare disparities, it is also important for healthcare institutions to address social determinants of health, invest in community-led organizations. Today I want to talk about the CLM, the community-led monitoring. We've seen that organizations are coming out to support CLM, Global Fund being one of them, PEFA being one of them. But again, you are coming back to fund the same person who is implementing to monitor them, to monitor themselves. Invest in community so that we can be able to monitor the programming and tell you where the gap is and how are we filling this gap together. Community-led monitoring can be a powerful tool in improving health well-being of key populations and empowering, promoting accountability, advocacy, and data collection. One of the things I want to end with is I want to end with an example and a story of one of us. There was a time I was going to see a friend, her name was Lucy, in the hotspot because she was using drugs and she had just given birth. I think she waited for me too long because there was traffic. So when I got there, I did not find her in the room, so I decided to walk in town to see if I'll find her in the streets. So when I got there, I found a lot of people in a huge circle, and I decided to go and check what was happening. Sadly, it was my friend who had stolen a person's phone for survival, for her to get drugs, and maybe to get something to eat because she wanted to breastfeed. And they were actually burning her to death simply because she stole a phone. These stories are real. Communities are dying day in and night. Why? Because they are looking for ways of survival. The only way to end this is for us to start having different conversations today. It's for us to start having conversations with community. We are saying healthcare is very important. We are grateful to you, our partners, for making sure that we have a great healthcare. We thank our government for welcoming partners to come and have those healthcare conversations. But let's talk about gender-based violence among population. Let's talk about these violences that we face day in, day out. All the time I go to do sex work, me returning back home to my children, it's never assured. As I have said, as communities, we can do it better if we work together. Thank you.
Thank you, Phelister. And our last amazing speaker will be Yevgeniya Kuvshynova. She is the executive director of all Ukrainian charitable organization Convictus Ukraine, which implements programs to combat HIV infection, tuberculosis, and other socially significant diseases, harm reduction programs, programs to support people affected by violence, and humanitarian programs to support people affected by war. Since 2017, she has been a delegate from the non-governmental HIV service organization in the National Council on TB and HIV/AIDS, which operates under the cabinet ministers of Ukraine as the highest advisory body for coordinating programs to combat the disease at the national level. With you, Yevgeniya.
Dear participants of the conference, dear colleagues, it is a great honor for me to be here to present the experience of Ukrainian civil society organization in ensuring the sustainability of harm reduction programs and access to treatment services for key populations in the war time. The war started by Russia has been going on in our country for 8 years and 480 days. On February 24th, 2022, we woke up in the morning to large-scale attack in our country. For over a year now, we have been witnesses of killing people, violence, abuse, and the destruction of our cities. There is no region in Ukraine that has not been affected by the war. With courage and commitment, Ukrainians are fighting for our home, our freedom, our identity. Before the start of full-scale war, the population of Ukraine was estimated at 42 million. There are 258,000 people living with HIV and 366,000 people who use drugs. This war resulted in the biggest migration of Europe since World War II, with 35% of Ukrainians leaving their homes and becoming internally displaced persons or refugees. February the 24th, 2022, this day divided our lives into before and after. In recent years, our country has made significant progress in harm reduction programs and programs to combat HIV, tuberculosis, and our diseases. A public health system reform was launched. A transition plan was intimated, according to which harm reduction, prevention, and care programs were transformed from global fund support to domestic fund. Ukraine managed to reduce HIV-related morbidity and mortality, and antiviral therapy was available to all who needed it. The opioid substitution therapy program in the country has achieved significant results and considered one of the largest programs in Eastern Europe and Central Asia. We plan to continue working in improving the quality of our programs, eliminating discrimination against key populations, and changing our law to ensure decriminalization. In the first day of the large-scale war, when our country was covered with fire, fear, and pain, we still hoped the attacks would be stopped. However, the war still continues. Bucha, Irpin, Borodyanka, Gostomel are the usual roads that our organization team members travel daily to offer harm reduction services to people who use drugs. Here, in these beautiful cities, as in many other cities of Ukraine, a green corridor has been created for key populations to access treatment for HIV, tuberculosis, hepatitis, and OST. The occupation of these cities by Russian troops shows the whole world cold-blooded cruelty. Mass shooting of civilians, murder of children, mass graves, rapes. All this time, we as Ukrainians have been asking ourselves the same question: how this can be happening in the 21st century in front of the whole world? Ukraine has a very strong civil society. Civil society organizations are a driving force behind reforms, innovations, programs, and Ukrainian movement to the European Union. In this difficult time, in the face of the unprecedented danger, civil society organizations addressing the basic needs of Ukrainians in parity with government institutions. From the very first day of the war, we started helping with evacuation and delivering vital medicines to places where doctors could not reach. We created a network of shelters and started providing a wide range of humanitarian aid. Despite the shelling and destroyed roads in the Kyiv region, our team members delivered medicines by bicycle, risking their lives. Our colleagues from partners organizations covered dangerous routes in the other regions of Ukraine to ensure that people are not left without help. Many years of experience, strong partnerships with government institutions, and the resilience of Ukrainians allowed us to continue providing services in these challenging conditions. Despite the issues with logistics, most OSCE patients in country has uninterrupted access to their therapy. Thanks for our partners in the Eastern Europe and Central Asia, we have received additional resources to provide humanitarian assistance for key populations. International partners have become an important source of assistance and support for Ukrainian refugees in other countries. The war continues. Mariupol, Bakhmut, Zaporizhzhia, Chernihiv, many Ukrainian cities have been turned to ashes. Russian troops are deliberately destroying buildings, churches, schools, hospitals, attack evacuation corridors, setting up filtration camps, deporting, raping, torturing, and killing civilians in the occupied territories. The Independent International Commission on Inquiry in Ukraine has documented numerous violations of international law and found that Russian attacks on Ukrainian energy infrastructures and the use of torture may constitute crime against humanity. How should the world order and work on international agencies change to prevent the recurrence of such tragedy? A state that has been consistently destroying civil society for years poses a threat to the world peace. However, international community has long turned a blind eye to the way Russia committed crimes in the various countries around the world. They remained unpunished. Today in Ukraine, access to essential services and treatment for key population is becoming critical. Ukraine government priorities have been changing to focus on the military needs. At the same time, migration creates barriers to access to IRT and OST programs, and increased stigma and discrimination against key populations. The war has revealed same gaps in Ukrainian legislation that need to be addressed soon to make sure that key populations have access to services and can protect their lives. At the same time, the war is not a reason for us to stop our activities. Right now, during the war, syringe exchange programs are finally being launched in prisons in Ukraine. Harm reduction, HIV prevention, healthcare and programs for key population continues to operate and are not slowing down as compared to the previous period. How should the priorities of country be transformed to put human rights at the center? This is not conflict between two states, but a confrontation between two systems, authoritarianism and democracy. We want to build a state where the rights of every person are protected. People in different countries are fighting for their rights and freedoms in difficult conditions. And the problems we face today do not fit predefined solutions. However, the world is very interconnected. The voices of millions of people around the world can change history faster than the actions of international agencies. It is not enough to pass the right laws and create the right institutions. Human rights should become values, and the world should unite around the idea of protected human rights and freedoms. Only then we can overcome challenges in inequality. I would like to express my gratitude to all countries, all organizations, and to every person who supports Ukraine. In this war, we are fighting for freedom in all its manifestations. And we are paying a very high price for it. We call on the world to stand in solidarity with Ukrainians and support our country. We continue our fight. Thank you.
I would like to ask for another round of applause for our four amazing speakers: Professor James Ward, Dr. Seree Nonthasoot, Phelister Abdalla, and Yevgeniya Kuvshynova. Thank you.